Dr. Kelly McCants grew up in Jacksonville, Florida, Tuscaloosa, Alabama, and he says he drew his inspiration from his mother and older brother. He's the first physician and only the fourth college graduate among 54 members of his extended family. His brother, who's now a police captain, and his mother, who went back to school at the age of 40, were the first and second college graduates. Really impressive. Dr. McCants attended Tennessee State University in Nashville before going to Meharry Medical College, also in Nashville. He completed his internship, residency, and fellowship at the University of Louisville. And he returned to Louisville after a stint in Atlanta, Georgia, at the Piedmont Hospital, where he was director of cardiac transplantation. Dr. McCants is the acting executive director of the newly formed Norton Healthcare Institute for Health Equity and serves as Norton Healthcare's medical director of advanced heart failure. Dr. McCants has a true passion for addressing health disparities by identifying and remove obstacles that prevent people in underserved areas from receiving health care. Real pleasure to have Dr. Kelly McCants with us today. And I should note that Dr. McCants has no relevant relationships to disclose. So, Dr. McCants.
Thank you so much, Dr. Flynn, for that introduction. I really appreciate it. Let me start by sharing my screen. So again, thank you for allowing me to steal a few minutes from your lunchtime to discuss such an important issue. When it comes to women's health, we do understand that we have a lot of work to do. And I realize that I may not have been the original speaker, but I will try to do this subject justice, because when we're thinking about women and their health, particularly in the cardiovascular space, what we're really talking about are disparities and how to make their care equitable. So as we move through this presentation, we have a few objectives that we will make sure that we achieve. And I'm not going to read you each one of these objectives, but I do want to summarize and say that there are specific gender differences that put women at risk for higher prevalence of cardiovascular disease. And as we move through this presentation, that will become apparent. The other point is that women often present different clinically, particularly when we start dealing with chest pain and myocardial infarction. Women have a different clinical presentation than men. And so we want to make sure that we understand what that looks like and to really be in tune with that from a provider standpoint. I think there's no other disease state that highlights the disparities in women's health and in many vulnerable or disadvantaged patient populations other than heart failure. You know, heart failure tends to be that disease state that if there's disparities, you can easily pull it out. And so we'll talk a little bit about what that looks like from a heart failure standpoint. And then finally, I think we do understand that women have been historically underrepresented in clinical trials, and not just in cardiovascular clinical trials, but clinical trials as a whole. So how do we educate, promote, and bring awareness to the importance of having women included in the clinical trial space to make sure we understand how to achieve great outcomes regardless of your gender? And so the first few slides I'm going to use to really just set the stage for what we're talking about. And when it comes to heart disease, men and women are not created equal. Well, not just in heart disease, but in many areas, men and women are not created equal. And we do know that women are the smartest of the gender. But in this particular case, I think it's important to understand that almost 300 million women across the world are diagnosed with some type of cardiovascular disease. And in fact, in 2019, almost 9 million women died as a result. And so this is something that cannot go under recognized. And we want to make sure that we use forums like today's forum to really bring awareness to the point that women truly are at risk for cardiovascular disease. And I think I know this is a lunchtime period and people are pretty busy, but this one particular slide sums up the entire presentation. Across the world, 35% of all deaths, particularly in women, are associated with cardiovascular disease. And we do know that women are understudied, they're underrecognized, they're underdiagnosed, and undertreated, particularly in the cardiovascular space. And as we mentioned earlier, they're certainly underrepresented in clinical trials. And so we want to make sure that we highlight the specifics that will bring our attention to how women present in the cardiovascular space and make sure that we continue to bring awareness to this issue. We're known for a few things in the state of Kentucky, but as we're viewing this heat map, you can pick out where Kentucky is. One of the things that, of course, we're known for is the Kentucky Derby. But what we should also realize is that we are certainly known for heart disease, particularly in women of young age. So at 35 years of age, we clearly start to see that in the southeastern United States, there is a clear disparity in what cardiovascular disease looks like in women. In Kentucky, for all practical purposes, is leading the charge. And we're all very aware or very keen of the well-established risk factors that are the usual players in cardiovascular disease, like hypertension, diabetes, and obesity or sedentary lifestyle. But when it comes to the female gender, there are under-recognized risk factors that we must make sure that we address and that we are aware of. And there are also sex-specific risk factors, which are listed to the left here, where once you start to lose that beneficial effect of estrogen, that cardiovascular disease and many other diseases become even more apparent. But I think one of the key takeaways of today's presentation are these under-recognized factors that are associated with gender influence, which can include socioeconomic status, psychosocial risk factors, and then the environment that women live, work, and play in. These are very important risk factors that are often under-recognized when women present, particularly to a cardiovascular specialist. And so I want to make sure that we go a little bit slowly as we move through this particular clinical registry. Now, this was published in Circulation in 2018, and it was presented at the American Heart Association also in that same year. But this particular article looks at sex differences in the presentation and perception of symptoms among patients that present with a myocardial infarction. And so I'm going to speak a little bit slowly as we move through this VIRGO registry, because there are some key takeaways that really continue to set the stage for this presentation. So in this VIRGO registry, there were about 2,000 women and about 1,000 men that were interviewed at the ages of 18 and 55. They were interviewed at the time of their acute myocardial presentation across 103 US hospitals. And results, I want to make a few things apparent. We've always heard that women present differently with cardiovascular disease, but I want to be clear in that in this particular study, 87% and 89% of men presented with the hallmark symptom of chest pain as it relates to their acute myocardial infarction. And so that is the main takeaway point, that women truly, like men, present with that hallmark symptom. So we don't want to deny that for the providers that are on the call here. But what is also apparent is that women present with greater than 3 other associated symptoms, which may be epigastric discomfort, palpitations, dizziness, or other non-specific symptoms that sometimes cloud the clinical picture. And when we look at that second bullet point, in comparison with men, women were more likely to perceive stress and anxiety as their contributing cause for their cardiovascular presentation, which is very different than men. And then finally, I think the most concerning point is that approximately 29.5% of women actually sought medical care before their acute episode, and 53% of women reported that their provider did not think their symptoms were related to their cardiovascular disease or their acute presentation. And to me, this is the most concerning point, is that as providers, we often have warning signs. And in this particular study, the women presented before their acute myocardial event, and still their provider was not in tune with their symptoms at the time of presentation. And so as we look at this study a little bit further, this slide is a little bit busy, but what I want to draw your attention to is the left side of the table. And it just speaks about the demographics of women in this particular VIRGO study. And so when we think about the age range, 18 to 55 for women, which are represented in the first column, this was predominantly white females in this particular study. They were, for the most part, had a higher education and lived in a metropolitan area. When we look at the past medical history, and I've boxed out what I think is extremely important, women were 2 times likely to already have had a history of congestive heart failure. The traditional risk factors that we spoke about earlier, including hypertension, diabetes, and obesity, were much more apparent in women. And the other most important point is that if you look at the bottom column or the bottom row, women were more likely to present with chronic kidney disease. And for the providers on the call or the cardiologists on the call, we do understand that the heart has one job, and that's to pump to the kidneys. And when the kidneys are not happy, it tells you the overall state of health in that particular person when they have cardiovascular disease. And so even in this study, it points out that women, while they experience the same traditional risk factors, they were more likely to have a worse outcome based on these risk factors at presentation. And I think this point is also important. When you look at the psychosocial history, almost 40% of the women in this particular trial had some degree of depression at the time of their presentation. Now, it's important to understand that depression in itself has risk factors in terms of stress, but we should not focus on the psychosocial presentation in women in this particular study, but do understand that there is a link between depression and cardiovascular disease. And so this is just a cartoon that's a little bit lighter than that presentation. And the only thing I wanted to point out, when you look at the slide to the left, when you look at the man in this presentation, he has about 4 different symptoms at presentation. But for women, there's a laundry list of presentation that, as providers in terms of clinical symptoms, that we must be cautious of. And sometimes the presentation women is just associated with extreme fatigue. When you look at what's highlighted on the right here, very busy slide with a lot of numbers, but I think the most important point to understand is that when you have numbers like 90%, 80%, truly women are at a higher risk of cardiovascular disease than their male counterparts. So let's shift gears just a little bit. But I think what I wanted to do with those first few slides is just highlight the fact that the stigma of heart disease being a man's disease is not necessarily true. And in fact, when it comes to heart failure, women over the age of 65 present with more congestive heart failure than men. And I think the traditional risk factors of hypertension, hyperlipidemia, diabetes, and ischemic heart disease mirror the health disparities that have already been pointed out over the last 1.5 years. But we do need to understand that these disparities are even more prevalent when we start speaking about African-American women as well. And so why do Black women have more heart disease? This is another picture just to lighten the mood just a little bit. So these are my parents in their 30s. I'm not sure what's going on in this particular slide, but I am certain that my father is not happy. And I'm also certain that the stress level of my mom is driving her hypertension in this particular picture. But, you know, I want to make another point. When we start thinking about the role of race, particularly as it relates to hypertension, this is just a caption from a study that I thought was very interesting. And it says that race conscious African Americans, particularly women, had a significantly higher diastolic blood pressure than those that were not racially conscious. And so the fact that you have risk factors for cardiovascular disease, which may or may not be hypertension, but the fact that in your environment, whether that be your work environment, your play environment, or your social environment, anytime you factor in race, your blood pressure tends to rise. And a lot of times that's associated with cortisol and stress release hormones, but it has been well recognized in the literature. And again, it's more apparent, particularly when we start thinking about African American women. And then the second point here, I know this is primarily a cardiovascular talk, but I want to highlight the fact that Black women in general are 22% more likely to die from heart disease, and 71% more likely to die from cervical cancer, and 243% more likely to die from pregnancy-related issues, which for many African American women, we're talking about preeclampsia and the effect of hypertension during their gestation period. And so when we start comparing disparities in gender and race, these things continue to be important. When you look at the ratio of deaths from cardiovascular disease for Black females and white females, it is clear that women overall, regardless of gender, are at risk, but that risk continues to be more apparent when you get down and separate race into African American women versus non-African American women. And when we first started out, we showed the heat map that showed that in many areas of the Southeast, that cardiovascular disparity, particularly as it relates to women, starts to happen at about the 35 age group. Well, in African American women, it starts to happen at the age of 20, which is highlighted in the box that I have here in yellow. Furthermore, when we start speaking about risk factors, high blood pressure, diabetes, obesity, but the risk of heart attack or stroke, particularly when you factor in obesity in Black women, increased the chance by 117%. And it did not have that same increase for white women that were obese. So when we start thinking about disparities, which is really what we're talking about when we think about women and their contribution or lack thereof to the cardiovascular space as it relates to their outcomes, their ability to participate in trials, and how we are even aware of the prevalence of cardiovascular disease in that gender. The same thing continues to happen when you look at race. So it doesn't really matter what the chronic disease is. It could be diabetes, it could be hypertension, it could be lung cancer, breast cancer. Truly, those vulnerable populations tend to have the disparate healthcare and disparate outcomes that become increasingly important. And here's another representation of that in a bar graph standpoint, looking at cardiovascular disease, stroke, and lung, as well as breast cancer, comparing white and Black females. And African-American females are represented in red here. And so again, just showing that even more disparities as it relates to cardiovascular disease, stroke, lung cancer, and breast cancer. And so when we start thinking about the evidence to support the fact that gender is important, I think the heart failure literature, and this was taken from the Heart Failure Society of America guidelines, really gets at this issue. when you read the top statement, it says heart failure is a prevalent condition in women, African American, and elderly. I think that those particular groups continue to be underrepresented in clinical trials. And sometimes we think that the outcomes that we see in clinical trials can be generally applied equally to these groups, but that's not always the case. And so here's just a very bold statement that says women in cardiovascular trials is widely acknowledged that the appropriate representation of women in clinical trials is crucial, but historically they've been underrepresented and often even excluded from participation. And so we must be intentional about including women in our clinical trials so that we really understand what the outcomes actually are. And so when we start thinking about research and clinical trials and workforce, I want to make a few comments in terms of what those disparities continue to look like. When we look at physician workforce, African Americans make up about 4% of the physician workforce, and female providers make up probably about 8 to 10% of the physician workforce. When we start looking at which physicians are funded by the NIH to do research, again, that disparity continues to become important. And so when we think about who's actually enrolling patients in clinical trials, if there's no women there to have those crucial conversations about the importance of enrolling in clinical trials, then you're less likely to be successful with that particular gender. And so when we start thinking about cardiovascular trials, particularly heart failure trials, I have a few listed on the side here with Paradigm, DAPA-HF, MUST, and SCUD-HEF. You see that African American and women representation in these trials usually approaches about 8 to 15%. When we start thinking about our AICD or our defibrillator trials, these are the disparities that exist between age, gender, and race. When we look at landmark trials that prove that defibrillators prevent sudden cardiac death, women were only included in about 8 to 20% of those clinical trials. And the same thing for African Americans, and the same thing for elderly. And so this triad of disparities continue to exist, but I think that heart failure certainly highlights what this looks like. So what are our strategies to increase the proportion of women in these cardiovascular trials? And if you notice on this particular slide, I made the logo for the Institute for Health Equity bigger, because what we're talking about is how to make things equitable. And when I look at what this slide is highlighting, removing barriers, meeting people where they are, being inclusive, exchanging knowledge, and promotion and advocacy, these are all the same things that the Institute for Health Equity is engaged in doing in terms of removing barriers to make sure there's equal access to care for women in vulnerable communities as well. And so let's just take removing barriers, for example. We do understand that for many of our patients, particularly the ones in the West End, transportation is an issue. What also holds true for women, regardless of their location. You know, arranging childcare to make sure that you can actually come to your follow-up visits and actually participate in clinical trials becomes a burden or a barrier in many cases. And so as providers and those that are considering how to increase participation for women in these clinical trials, you have to consider that. And then outreach in terms of meeting women where they are. You know, I go back to how sometimes we think about barbershop campaigns and getting into the barbershops to talk about hypertension in vulnerable populations. Well, what will be our strategies to make sure we meet women where they are? And maybe it's the mobile strategy. You know, when we think about what we've done in cancer with our mammography unit and our screenings, making sure that we can actually have locations to meet women in the communities that they live, work, and play becomes increasingly important. But I also want to talk about biases. I think from a provider standpoint, we are challenged with how we refer patients for procedures in respect to their age, their race, and their gender. And this is just a study that I pulled out looking at different or diverse patient populations. And it says MD or medical provider decision-making and physician interpretation for clinical scenarios. And again, we're speaking about cardiology. It says that African Americans are 40% less likely to be referred for cardiac cath. You could easily substitute women instead of African Americans in this particular slide, and you would still see very similar numbers in terms of how they're less likely to be referred for procedures that we know can be beneficial. And to make this point more apparent, when we think about how research is failing women and making them less healthy, I love this quote that says the lack of female representation in both preclinical studies and clinical trials has put women at a greater risk for adverse events and outcomes. And in the bottom caption here, I have highlighted a very important trial, which looked at coronary artery bypass grafting versus medical therapy. There were 3 landmark trials that were done over 15 years ago that said that bypass grafting was better than medical therapy for patients that present with significant coronary disease that are symptomatic. Well, when you look at the 3,000 participants in this study, less than 3.4% were women. We have got to do a better job in being intentional about enrolling our women in these cardiovascular studies. Because if I were to look at this interpretation or look at this data, I would wonder if we're looking at CABG versus medical therapy, can we generally apply that information or what we learned from that trial to women? And I would say, if I were a pure scientist, that there were not enough women included in the trial to understand that CABG is of benefit. And so I think partnering with industry is one of the things that we can do to make sure that we're inclusive of women and intentional of enrolling women in our clinical trials. And I know this slide is busy. It's not meant for you to understand or be able to read each and every point. But when we think about drug-eluting stents, this is an example of how having industry support the utilization of drug-eluting stents and actually enrolling women in the clinical trial to generate similar outcomes or to demonstrate if there are similar outcomes. The same thing with safe PCI. For many of the folks on the call, when someone comes in and needs a diagnostic heart cath, sometimes we can approach with a radial approach, or sometimes we can approach with a traditional approach through the groin, but we have no data to understand if there's any gender differences in those different presentations. And so having a trial that focuses specifically on women with that approach is important. And this again is demonstrated in this Women's International Transcatheter Aortic Valve or TAVR registry, being intentional about making sure women are included in TAVR registries to make sure that we understand the benefits or lack thereof of TAVR in patients that have significant aortic stenosis. And so I love this quote. I won't read it through in its entirety, but I think that women are being very vocal, and it's important to make sure that from an awareness standpoint, when we see a disparity or we see a way to be inclusive, that we highlight it. And so this lady is saying that there are common misrepresentations around heart disease, and often the perception is that women are having psychosocial events like a panic attack, when really we must make sure that we consider the cardiovascular perspective in those presentations. And I think this is also important in terms of how women perceive their leading cause of death. When we start thinking about awareness and how to promote it and what perception looks like. So when we look at 2 different time periods from 2009 and 2019, when in 2009, the perception of women surveyed was that cardiovascular disease was a leading killer amongst women. Well, that perception decreased in 2019. And if you see, when it comes to cancer, and particularly breast cancer, um, that became the most feared cause of death from a perception standpoint. And what that says to me is that we've continued to have awareness around cancer and breast cancer in particular for around women as they present with chronic diseases. But we still must understand that cardiovascular disease is still the leading cause of death for women. And so with that, I want to shift gears. It's hard for me to give any presentation without speaking about the Institute for Health Equity and how it plays into disparities and being equitable in how we deliver care, which is really the crux of what we're talking about today. And so I just wanted to kind of show you some data from a heart failure standpoint and really get down into the differences that gender and race play within Louisville and our system as it relates to presentations around heart failure. So again, this slide is a little bit busy, but what we're looking at is about 13 or 14,000 admissions for heart failure over the past 3 years. And if you look at the age groups that I have highlighted here, from 20 to 40, let's say, the gender difference becomes apparent for women presenting with heart failure, almost 54%. And then at the other end of the spectrum, when you're above the age of 75, again, 59% more women present to Norton Healthcare with the diagnosis of heart failure than men. However, if you read the literature, it will tell you that heart failure is a older white male's disease, but that is not the case in the city of Louisville, and that is not the case in many of our metropolitan areas. And I think, again, the heart failure disease state is one of the major states where this becomes increasingly apparent. And so when we look at this particular young female, again, I showed you that heart failure presents at a young age for females in the city of Louisville, particularly African-American females that present from vulnerable communities. And when we start to think about the neighborhoods where we're hoping to have a significant impact in terms of disparities, 86% of African-Americans in the city of Louisville live in these neighborhoods where there's challenges in education, income, transportation, as identified earlier. But I think the most important point here is that women, 60%, are the head of the households in these particular areas. And so when we start thinking about, again, enrollment in clinical trials, when we start thinking about having access to healthcare, when we think about being able to come to your clinic visit while still maintaining employment, it becomes increasingly challenging for women in these communities. And this is a closer look at the demographics in the Portland, Russell, and California area. But I want to draw your attention to the left corner of the pie graph here. And you see that when we're talking about vulnerable communities and site-based investments into our neighborhoods, what we're really talking about are taking care of women and children. And pink here represents the female gender. And so when we think about these vulnerable areas, we must make sure that we're inclusive of women's services as well. And finally, I'm almost done. And so when we look at the goals for health equity, obviously expanding access to care in West Louisville. But if you go all the way down to the bottom, we must make sure that we expand women's health services, not just around cardiovascular care, but total women's health services. And we're working very closely with our women's health service line and Mary Schubert and her team to make sure that we're comprehensive in our approaches in those areas. And finally, we'll get to the point where there's time for questions, but I wanted to finish with this quote: "I raise my voice not so I can shout, but so that those without a voice can be heard. We cannot succeed when half of us are held back." And again, I want to thank you for giving me the opportunity to make some brief points about disparities as it relates to women in cardiovascular disease. And I'll pause for any questions at this time.
Thank you very much, Dr. McCants. That was fascinating. I think it brought up a lot of important topics. If I could just maybe start off with a couple of questions while people are entering them. So you spent a lot of time talking about the differences between males and females. Can you go into a little bit about why you think there's such differences besides access? And I was really struck by the symptoms that females present with over what males are presented. It looks like there was 4 main for men and then far more varied. Is it just that they're so atypical in the presentation, or is it just the bias where people think, oh, it's a female, low risk of heart disease?
Yeah, and Joe, thanks for the question. I think it's a very loaded question and answer, but if I had to summarize it, I would say that the bias that we have toward women presenting with at least chest pain, acute MIs, is apparent. And it's because it's not just the classic chest pain, it's the, oh, I feel fatigued, I have something is just off, and the description is often more vague. And as providers, we kind of let that shift our focus. But based on what we learned from the VIRGO study here, those are the people where we actually should dive even further and focus more on cardiovascular disease, because we do know that that presentation is often different.
So while I have the microphone, if I could ask a couple other questions. So why do you think, I was really struck by the stark difference of participation in clinical trials between males and females. Is there anything that we think is really the cause? And then what can we do at Norton Healthcare to try to right that ship in how we're accruing to trials?
Great, another great question. I think that, being prepared to have those conversations, making sure that we have female providers on the front lines discussing those risk factors and those risks and benefits of enrolling in clinical trials, how even something down to a scheduling standpoint, how to, as women, we understand that your schedule, particularly if you're married and you have children, how that may fit into research follow-up. Just making sure that we're informative in how we discuss participation in clinical trials, I think is crucial. But not only that, Joe, being able to attract clinical trials that focus on women. You have to have a robust research program to make sure that you can do those things. And I think we're starting to move in that direction.
Great. Another question for you. It seemed somewhat surprising. Why, when we looked at the referral patterns for advanced referrals, it looked like minority providers had a lower participation. Did I read those slides incorrectly? I was actually a little shocked by that.
Yeah, and that's interesting, because you would think that from a minority standpoint, if you are able to identify or have those trusting relationships, that you're likely to decrease that bias. But that's not always the case. And I think that's just one particular study that demonstrates that even being an African-American provider doesn't always mean that you're going to make the connection to make the referral, because there's still trust barriers that exist. And so I think that while we're hopeful that if we mirror our community, that we can achieve the outcomes that we're trying to, but it still lets us know that there's work to be done even beyond that from an education standpoint.
Perfect. Any other questions for Dr. McCants? Well, I will tell you, that was a fascinating discussion. Thank you very much. That was, I think, really an important topic, and I learned a lot, and I'm sure everybody did. So thank you for that great presentation. And I want to thank everyone for joining us for the program today. I think here's one other question, comments. Again, agreeing that thanks for educating us today and focusing on these important topics. It was really very helpful.